Here we are. Thank you very much. The topic of this speech is surgery in the hospital of the future. Not that easy to imagine what the future will be. But I guess you also are convinced that in God we trust, but all others bring data. So let me start with some data from the beginning. If we look at some data from the OECD indicators as health indicators, let me show you a few data on health status, life expectancy and mortality, for example. So life expectancy at birth has increased everywhere, but you see there are substantial differences on your left-hand side between countries. The red one is the mean value for OECD countries. And if we look at the relation between life expectancy, a GDP product per capita, you see that there is a direct relationship between the richness of a country and its life expectancy, at least when you almost reach a top where it is much more difficult to interpret the data. Few data on health workforce, number of physicians and nurses, for example. There is a huge difference in OECD countries in the number of physicians per capita. It's increasing almost everywhere, but you see on your left-hand graph that, for example, Greece has a tremendous number of physicians per capita respect to the mean value of the OECD countries. And there is a huge variation between one country and the other. If we look in more detail at the number of medical specialists and the number of general practitioners in each country, you see that the pale blue are the specialists, and the line at the bottom, and the bottom are the general practitioners. This huge difference make a lot of difference in the handling of your healthcare force and in hospitals, I would say. Few numbers, a few data on the number of nurses per capita. Again, it's increasing, but again, enormous difference between one country and the other. Let me show now some data on diagnostics and treatments and how much of these is used in each country. For example, the number of magnetic resonance imaging, CT scanners, that is increasing in all OECD countries. It varies enormously between one country and the other. We already been shown this data yesterday by our Japanese colleagues that showed that in Japan, the number of these technological devices is really enormous. But as you can see, and it is very surprising, there are countries such as Germany or Spain that are far behind the mean value of the OECD countries. And if we look at the number of performed MRI and CT scans per capita, you again see that, surprisingly enough, Greece is the top performer, followed by United States. And there are many countries, some very developed countries in the field of health, such as Denmark, that are far behind the mean OECD value. This is the graph of the average length of stay in hospitals that is falling in nearly all OECD countries. This reflects some efficiency gains, but again, you see a huge variation between one country and the other. Access to care, financial barriers. We are lucky enough, most of our healthcare systems are providing care for all the population, except few countries. This is waiting lists and more than 4 months for elective surgery. You see the longest are in Canada, Sweden, Norway, and UK. But as you may know, the UK is going better and better every year because they set targets and they are reaching that target precisely. Health expenditure and financing. Again, health expenditure per capita varies widely across OECD countries. And you see the mean value, the red line for OECD, and many countries, very surprisingly, very below the mean value of OECD. A similar situation is if you plot this number in percentage of the GDP dedicated to health. I found this interesting paper, very recently published on The Lancet, an estimation of the global volume of surgery, a modeling strategy based on available data. Why this is interesting? Because they were able to show a direct relationship between the number of surgeries performed in a country and the expenditure for health of that country. This means that if in a country where a lot of money is invested for health, there is a huge increase in the number of surgery performed. And if we look at data more closely, you see that here is the expenditure for poor, low, and middle expenditure countries and high expenditure countries. So as you can see, the main estimated surgical rate per population is increasing a lot and is amazingly high for high expenditure countries. There are only 38 countries with more than tenfold increase in the percentage of surgeries. And if you see the last line, sorry, the pointer is not working well, so the share of global population, you see that enormous amount of surgery that the high expenditure countries is done only in 15% of the global population in the world. So the question now is, the most important challenges for our healthcare systems are probably sustainability, access to care, and could be, for very high expenditure countries, avoid excess unnecessary care. It's probably a new question, this one, and safety, obviously. So we move to the future of hospitals. Difficult to say something very simple. So few slides on the historical background. You all know that the hospital has changed really tremendously over time. This is the main entrance of the Venice Hospital today. It used to be a church, but you go through this church and you enter the old hospital of Venice. It used to be a place of rest and prayer, and patients probably were waiting just for death or deliverance. And also, it was very clear that admission significantly increased your risk of dying. This is probably, after the presentation of Paolo, the only thing that is similar today sometimes. And this is the old ambulance in Venice. So, not very quick and safe transport. But this is the new Venice Hospital on the land, quite near town. Much different from an architectural point of view. So now, we are facing very complex pathways, multiple treatment approaches, different specialties, long-term provision of care. So many things are changing. And patients really increasingly have multiple chronic conditions, polypharmacy, aging, need for care and support at home, aging of populations, a very well-known concept. So what are the new challenges? The increase in citizen expectations, aging again, rising costs due to technological innovations. I showed you some data before. Reduction of public health expenditure, patient mobility, cross-border healthcare is going to be a major issue, at least in Europe, in a few years. Lack of healthcare professionals, mainly pediatricians and nurses, and restrictions imposed in public funding by commitments toward maintaining, for example, EU stability treaties. This paper was published in the New England Journal of Medicine 4 years ago, when in the US there was a high-level debate on the reform of healthcare. So what are the most important actions that they wanted to put in place? The first one is slowing the growth of healthcare spending. The second is complex healthcare system requires complex action on multiple fronts. Design care process and also clinical microsystems, healthcare organization accountable for the full continuum of patient care. This is the most important change if we consider the hospital as a separate entity from, for example, general practitioner care. Integration and networks mandatory, and the healthcare professionals' advocacy on any aspects of care. So it's a changing context, and hospitals are facing pressure to centralize in order to reduce costs, for example, and pressure to decentralize because they are becoming huge and very complex. And so there is a tendency to move care out of the hospital. So we are going to restructuring the hospital somehow. Throughout Europe in recent years, we show a reduction in the number of hospital beds. Beds are used more intensively, also thanks to the adoption, wide adoption of ambulatory surgery. There's been a huge increase in day surgery and day services, and they move from hospitals into community settings. This is the graph of showing the reduction in acute care hospital beds in the EU. And this is, again, the average length of stay for acute hospital only. So how things are changing. You all know that new operating theaters give us the opportunity to use incredibly new and performing technologies. Radiology is moving to telemedicine, ultrasound at the bed of the patient. Laboratory helps us with near-patient testings, microarrays, and many other. So what are the implications for healthcare? Surgery, minimal invasive and increased day surgery and short stay. Medicine, increased diagnostic work in primary care, again, out of the hospital, some testing. Infection control, I think we all agree it's a major problem in the hospital, and it could be much safer at home. And patient-centered care. So what will be the hospital? Are we deconstructing the hospital now? And what is left? Should this mean, for example, the creation of focus factories for high-throughput elective surgery? Or should we organize multidisciplinary teams and networks for messy and complex problems such as oncology or trauma centers or transplant units and so on? Integration with primary care for chronic disease management obviously is mandatory, and admission to hospital for an unnecessary condition should in the future, but also now, be seen as indicating a failure of the system. We're going to rethink the hospital, changing the physical structure, moving to home care, change the way also the staff of the hospital work, and fundamentally alter its relationship with primary care. Let me show you, some of you already know probably this slides from Nigel Lidwell of the NHS Trust and European Observatory on Systems and Policy that could help explain what I meant to say. So this is the structure of a traditional hospital. There is a ER, emergency department, outpatient, radiology, medical ward, surgical ward, theaters, ICU, and then pediatrics, maternity, pathology, and geriatrics that can be inside the hospital or quite near to the hospital. And now, in most part of the world, any emergency, any referral goes through the emergency room and then to the department. But probably, and it's also a reality in some countries already, a telephone triage will help us to distinguish the place where the patient can have the best care in different facilities. So we are destructuring the emergency care. Children care can be a side of the hospital, but also minor injury. Why should we keep them in the emergency room that is always crowded and minor injuries always wait hours and hours? Primary care, obviously, must be outside. So we could leave a medical assessment, a major trauma there. And we can also think to separate these structures. So what about medical ward? Do you think we still need a traditional medical ward? And geriatrics. Probably we don't need a geriatric department inside the hospital. We could change the way we think and create an intermediate and care and rehab outside the hospital. And what about ICU and theaters? Usually ICU are quite near to the theaters. But if we change, we could create a medium and high dependency ward that is not strictly related to surgery and theaters, but that could serve for any patient requiring high dependency, for example. Outpatients and the surgical ward. We could also remove surgical ward and put theaters near the high dependency, so that's for some theaters and others you don't need to have there probably. And so you see the hospital is now shaping as a very different shape. Ambulatory care we need in the outpatient department, but also we need some in the hospital. So the concept is now clear. We should move from isolated hospital to networks of hospitals, because probably the single one will not be able to support all the care we need. So this is a big change and requires, for example, new incentives for hospital, new skills for primary care. We should redesign the work of specialists in chronic disease, new roles in managing chronic and disease, and especially for nurses, a new mindset for hospital managers. So ambulatory surgery, that you all know, it is surgery, it's more than 70%, 80%, we could discuss. Should we rethink the whole system? I was looking for experiences recently published, because after following up the concept already explained, I was very curious to see if somebody would have start changing really. And I found an interesting paper recently published on the Australian and New Zealand Journal of Surgery, showing a new vision of surgical services in the Sydney area. What are they doing? So, Surgery Futures, a plan for Greater Sydney. It's just an example. What are they planning? And probably they are realizing this. I have very few data. So recommendation from Surgery Futures Project 2010. They recommended to create high-volume short-stay surgery centers, specialist centers, and emergency surgery in very separate settings. So it's a move toward the theory I showed you before. What's the high-volume short-stay surgery? It's defined as planned surgery procedures requiring the admission for up to 72 hours, and it includes, very surprisingly to me, both day-only and extended day-only surgery. That means 23-hour stay. And it builds on the experience, very big experience they have on the established extended day-only model. We could discuss this vision because, you know, could be a great idea, but could also be a step behind, because moving day patient to a unit where you can keep the patient overnight probably will change the way we work, but it's questionable if this will be or not a progress. This is just to show that the potential benefit of this high volume short-stay surgery unit is very similar to those already that we know very well for day surgery. So it's quality improvement, service improvement, staff satisfaction, and patient satisfaction improvement, and very cost-effective. What are the specialty centers? Well, they are clearly delineated referral roles within a geographical region, dedicated to some subspecialties. For example, very complex interventional radiology or other medical imaging and surgical support services, hand surgery or cataract surgery, similar thing. So they are moving to specialist centers some of the surgery that is currently done in day units. Again, specialist centers have some benefits, because there is a guaranteed workload, increased volume of patients, enhanced patient satisfaction, multidisciplinary care, easy to organize, increased efficiency, strengthened physician alignment. So very similar to the benefits demonstrated with the day surgery model and the high volume short stay surgery unit. This slide is from the WHO. There is an ongoing discussion there on the future of hospitals. What do we need for the future? Define function of hospitals, specialized services, redefine the role of hospital in a better balanced health systems, and are the successes to be reporting on hospital reform throughout the world? Up to now, I don't have any, I didn't find any data on this. And what is the potential role of the WHO and also of the international community and scientific associations? So, going back to the first question, very difficult to imagine the future, as you see. Me, as a surgeon, I have the feeling of this polar bear when I'm facing political decisions. And as John Keynes wrote, there is nothing a politician likes so little as to be well informed. It makes decision-making so complex and so difficult for them. Nevertheless, I'm sure that the opportunity for physicians to lead change and define the future of healthcare have never been greater. I'm convinced that a sustainable health system committed to high standards will not be realized without strong physician leadership. The future of health is something you can't predict, but it is something we must create. And physician leaders will embrace this and shape the future, in my opinion. Thank you very much for your attention.